OB GYN for shelf and step 2 sucks because most people just memorize random details without understanding them. Then they bomb their shelf into step 2. I did the same thing. I crammed every detail hoping that something would stick. That was until I learned a few core principles that made everything in OB click. In this video, I'm sharing actual paid course material, a group coaching call where you'll see real students who crush their shelf in step 2. These aren't just OB concepts. I will also show you the pattern recognition secrets that automatically improve your odds on nearly every step 2 in shelf question, regardless of what specialty it is. Watch how just understanding these principles transforms confusing OB questions into easy points. We are going to continue our discussion of OB, and I'm going to continue to tell you what the vignettes are going to be in advance. These are going to involve Molimina, in particular mastalgia. Mast is breast. I don't know why. Algia is pain. It's going to focus specifically on the mastalgia part. And then the second vignette will be about a fibroadenoma. The summary of key concepts. The first vignette is going to be about cyclic mastalgia and Molimina generally. We talked about last time that Molimina are the set of experiences before menstrual flow that indicate ovulation, classically. The reality is a little bit more complicated, but generally speaking, Molimina is thought to indicate ovulation or the post-ovulatory part of the cycle. There's a lot of overlap you'll see with premenstrual syndrome, PMS. But in a very general sense, Molimina are the normal version of PMS, which is a more extreme version of this. PMDD is basically the premenstrual dysphoric disorder would be even one step further of PMS. But they all fall within the same continuum, at least as far as I can tell. Molimina correlate with progesterone from the luteal phase. You'll see this sort of written as fact, but the reality is probably a little more complicated. And they're classically associated with the ovulatory cycles. And at least in vignettes, you'll see a lack of Molimina is associated with anovulatory cycles. They don't have the Molimina. In particular, like there's one of the more specific ones that is considered an indication of anovulatory cycles. Cyclic mastalgia means that it's mastalgia that happens with the cycle. And it's a classic sign of Molimina, particularly when it's associated with the upper outer quadrant of the breast. No one knows exactly why, or at least from what I could tell, no one knew why. But I'm going to guess that it's related to the fact that the upper outer quadrant has the greatest breast density. And you'll see this a lot. There's a lot of things associated with the upper outer quadrant. Fibroadenoma, which we'll talk about in the second vignette, is most common in the upper outer quadrant. Breast cancer also most common in the upper outer quadrant. And one very tantalizing hypothesis is that the higher gland density in the upper outer quadrant, there's just more glands, there's just more tissue there to grow. And so there's greater growth, greater swelling, and greater tenderness in that area in response to the progesterone. And that would kind of make sense. That would be associated with Molimina. Here is the vignette. What I'm going to do is I'm going to copy this. I'm going to put this into our Google Doc that you guys can write out both the concepts that are being represented as well as the pathophysiologic chronology. Put this up here at the top. So we'll do this. And then I'm going to put the summary of key concepts so you can have that information. And I'll give you, I don't know, maybe 5-10 minutes to go over this. If you're serious about maximizing your scores, join our 14-day mini course now. We'll send you 14 high-yield videos that break down the exact concepts and test strategies our students use for 260+ scores. Click the link in the description below now to get instant access. And instead of just seeing these just as words, really what we're trying to do is we're trying to say, like, does it really matter that she's 18? Probably not 18 specifically. Younger woman, sure. Maybe it makes a little bit more sense, but I don't think it has to be, right? Really, the important thing here is that this is just Molimina. And then we move forward. Instead of saying menarche was at 13 years old, initially her menses were irregular, like I used to just sit here and try to memorize all of these details. And I would get so overwhelmed by all of the different details of the vignette. And instead, the goal is that you're trying to identify, the concept is she has irregular menses initially, which makes total sense because that's just anovulation. But then over the past 3 years, she's had regular menses every 30 days. That implies that she's probably having ovulatory cycles. If you have regular menses, does it mean that it has to be ovulatory? No, but usually it will. If it's irregular, does it mean that it's anovulatory? Almost always. But they're just saying anovulation, then ovulation. And then finally, we get to the actual exam. Why are they telling us this? I could have put this in green, frankly. This is actually just Molimina. This is just the cyclic mastalgia. The point is that she's 3 weeks into her cycle, which means that she is in the post-ovulatory part, the luteal phase. And really, it's just now they're just talking about the physical exam. And in this case, this is pretty classic for Molimina. Andrew, what are your thoughts? I feel like if you don't understand it, it's my fault because I didn't explain it well enough.
No, I do understand what you're getting at here. I'm just not used to seeing it as structured as you're doing it, but definitely when we break it down like that, it does make sense, kind of making sense of the different aspects of the question and cutting the details down to the core concept.
Yeah, I would imagine. How do you feel when you do this? How does it feel to try to do this?
I notice I've been in core rotations over the past year, and I notice over the different rotations as they go on, like with shelf exams and New World and stuff, I gravitated towards doing this at times, although sometimes there can be like certain distracting concepts which may complicate, like distracting details. But I think explicitly taking note of such things instead of just going by feel like I've been doing could be more helpful in preventing the unforced errors, as you call it.
Yeah, I think that makes sense. Yeah, it sounds like you're recognizing like systemic sort of unforced errors that you're making. And it sounds like too that your mind is seeking simplicity. You can recognize that your mind wants to make it simpler, even though it's hard and there's like a bunch of details. Is that a fair sort of statement?
Yeah.
I guess I already went through the concepts part of this. What I'm going to do is I'm going to paste this into our Google Doc. You can see this is just my interpretation of what I think the concepts are. Really, there's just two, frankly. And like, it's actually pretty simple in many ways. And then I'm going to go over the pathophysiologic chronology. Whenever I make a pathophysiologic chronology, I start with a summary and then I give a detailed. The summary is a summary of concepts, really. And I do this because if I try to remember all of these specific details, it's really easy to get lost. So instead, I like my North Star of, in a big picture sense, really this is just luteal progesterone increases, where you get ovulation, you get corpus luteum. Corpus luteum is making progesterone. The progesterone causes more of a glandular as opposed to a ductal growth. And for whatever reason, probably because there's just a lot of glands there, the upper outer quadrant growth is more than other quadrants, was thought to be. And that presumably is leading to more swelling and tenderness in that area. Is this like 100% of the time? No, this is just like the classic description. You're going to see a lot of variation in the real world. When I asked like my wife, is it like, do you get breast tenderness like everywhere? Is it the Hester? Is it like the upper outer quadrant? She said, no, not really. It's not. There's going to be variation, but classically, what you'll see, certainly in Q banks, is that it's upper outer quadrant. The detailed you can read, but big picture, this is really what's going on. We're going to do a brief review of our menstrual Molimina, and let's start with Andrew. Andrew, can you tell me what are Molimina?
So the thing we were going over earlier, it's the symptoms preceding menstruation. The breast tenderness is one of them. For the reasons we discussed, the progesterone, also other stuff like cramping, pain, some of the mood symptoms potentially.
Perfect. I'm not sure actually that cramping falls under it, but certainly like mood stuff. Cramping, I think, is more associated with the menses itself from the uterine contractions. But yes, everything else you said was absolutely correct. Molimina are basically the experiences before menstrual flow that indicate ovulation. And Edwin, can you tell us menstrual Molimina, using what they are, the fact that they, at least classically, indicate ovulation, explain what, based on the fact that they are experiences before menstrual flow that indicate ovulation, what would it mean if they're absent classically?
Primary and ovulation?
Yeah, exactly. Because they tell you that there is, at least classically, are associated with ovulation. Classically, if you lack them, then it's a pretty good indicator, at least in some studies, that you are having anovulation. At least in one study, the negative predictive value was 93%, which is pretty crazy if you think about it. Just from one thing. June, what hormonal changes are associated with Molimina?
You said progesterone.
Yeah, exactly.
And the luteal phase.
Perfect. Yeah, exactly. Because progesterone is associated with the luteal phase because the corpus luteum releases progesterone. Excellent. And Kevin, what's the most classic sign of menstrual Molimina and what's the mastalgia for this?
Is it mastalgia?
Yeah, you got it. That's it. Yeah. What's the management?
Just NSAIDs.
Yeah. Analgesics is basically supportive raw NSAIDs. But basically, it's conservative. It's normal. It's not pathologic. Classically, it's not just breast tenderness, it's cyclic breast tenderness, technically. In the days or weeks leading up to menstruation, it's the fact that you have every cycle that you'll have breast pain in the days leading up to menstruation, and then it'll stop once you have menstruation. Constant breast pain, in other words, is not a sign of Molimina. Great. Lady, breast tenderness during the cycle. Why is this thought to happen? You know, this is like, a lot of this stuff is, I think, speculation. I think falls under the realm of informed speculation, but I don't know how you would, like, these would be difficult experiments to do in the real world to prove definitively. But why is this thought to happen?
I don't know, maybe the increase in the progesterone, but not sure how.
Yeah, good. Progesterone causes the growth of what? The glands that produce like the milk, or the ducts that carry the milk from the glands to the nipple?
I would think the glands that
Yeah, it causes glandular growth. Can you think of a reason, this much we do know, can you think of a reason why that might cause pain and tenderness in particular?
maybe just because of the pressure that they grow the glands over the tissue.
Yeah, exactly. Yeah. They're going to grow. Estrogen and progesterone cause different parts of the breast swelling, breasts to grow, and that's going to cause swelling and soreness and pain. Right? And estrogen causes the fat in the ducts to grow. And if you had to guess, high estrogen levels, Sahith, what kind of breast pain would high estrogen levels cause generally?
Ductal pain.
Yeah, I don't know that a woman would ever come in and say, "Oh, doc, I think my breast ducts are hurting." They would just say that it's generalized nipple and like just overall pain, because I guess ducts are everywhere. I don't know. That's speculation. And yeah, and it causes fat and ductal growth and symmetric growth. Presumably, it's going to cause symmetric growth everywhere. And this is why, classically at least, it's associated with nipple soreness or generalized mastalgia. Sophia, how about progesterone? We just mentioned that it's associated with growth where? In which part of the breast?
Yeah, glandular portion of the
Yeah, exactly. Like this stuff, in other words. And the mammary glands, the things that are making the milk. And Sophia, where is breast tissue density greatest? Which part of the breast?
the upper outer quadrant.
Got it. Now remember that. You can take that to the bank. The upper outer quadrant.
Would that be number 3 in this illustration?
Hard to yeah, 3 would be the upper part. I think it looks like the upper outer quadrant. I could convince myself, but certainly the upper part. This looks like it's bisecting the nipple though. This is probably like in between the upper outer and the upper inner quadrant. But the part that has been cut off, that would be the upper outer quadrant, if that makes sense. But in other words, it's the part that's, if you look at your chest, it's the part that's going to be closest to your axilla, to your armpit. Wanji, progesterone, it's associated with breast tenderness where?
You mean location?
Yeah. Which part of the breast?
Upper outer quadrant.
Got it. Yeah. And Wanji, can you, based on the location where the breast tissue density is greatest, can you speculate as to why malignant pain is most classic? Or where malignant pain is most classic?
The same location like upper outer quadrant.
Yeah, exactly. And why would that make sense?
Because luteal phase increase progesterone and then the gland increase.
Yeah, exactly. Progesterone causes mammary gland growth, but again, why would it be upper outer quadrant? You're right, those things are definitely true, but why would it make sense? This is informed speculation, but why would it make the most sense that it would be in the upper outer quadrant?
Because they have like higher density there.
Yeah, exactly. If we've got more glands, more glandular tissue in the upper outer quadrant, and progesterone causes the glandular tissue to grow, it would make sense. That is the part that's going to hurt the most. That just makes total sense. Yeah. Cool. So these are going to be short. A lot of what you'll find is a lot of these OB lectures are going to be shorter than normal, than at least some of the other lectures that we have in the course. The reason is that I want to have like quick hitting ones that really just focus on the most salient points and that tie back to some sort of general concept or theme. That's it. Menstrual molimina experiences before menstrual flow that indicate ovulation. They correlate with progesterone from the luteal phase, and classically, they're highly associated with ovulatory cycles. And their lack is associated with anovulatory cycles. So you'll see this. Now that I've pointed this out, hopefully you'll start to see this in the Q banks that you're doing, and maybe even some of the NBMEs or on your test. Cyclic mastalgia is the classic sign of molimina, particularly with the upper outer quadrant. We don't exactly know why, but using informed speculation, we can deduce that it might have to do with the fact that the upper outer quadrant has the greatest breast density. And progesterone causes the mammary glands to grow, and there's a higher density of mammary glands in the upper outer quadrant. It would make sense that the upper outer quadrant would be most painful and tender. I'm going to give you guys, I've included all of this. I'm going to give you guys another couple minutes that you can finish your pathophysiological chronology. Give it your best shot, and then we will move on to the next vignette. I'm going to look at some of you guys' stuff. Lady says ovulation leads to molimina. Ovulation, yeah, essentially. That's pretty much it, actually. Yeah, that's actually even a better summary than mine. That's pretty much it. That's good. Born healthy, it's 15-year-old. Ovulation starts, immature HPA. and anovulatory cycles, then as mature HPA, and then regular cycles. Luteal phase, increased progesterone. Wow, that's good. Yeah, that's good. I like that. I really like that. Ovulation, Molimina. Yeah, that's pretty much it. Nice. Well done. Look at Andrews. Patient with irregular menstrual cycles, premenstrual pain from progesterone elevation. I like that. Premenstrual pain. Yes, I like that. Particularly in the breast. Good. Growth of glandular tissue, not parotid quadrants. Yeah. What I want you to get more towards, this is more like the step 1A, just as a point of this. What I would try to do is I try to break it down into the sentences and just say like sentence 1 and 2 is saying Molimina. Sentence 3, 4, 5 is really just anovulation, then ovulation, something like that. This is, I think, good. I think I like a lot of the ideas that you have. I would just try to maybe organize it a little bit more based on the sentences. The step 1B is the pathophysiologic chronology, and patient began menses 13 as expected. For this, it's more just like a formatting thing. Try and keep it, like you see how what lady has here is she has from the day that she's born all the way until she's presenting here with upper outer quadrant breast pain, she can explain all of those signs in chronologic order. I think it's tempting to just say that, I guess you did do that. Menses at age 13, expected pubertal changes good. Immature HPA, so initially regular, corrected cycles, last month, 2 weeks ago. Later part of the cycle was progesterone elevation. Yeah, that's actually, sorry, I take it back. Yours is in chronologic order. It's just not starting from the day that she's born, but it's starting from the part that's most relevant. But that actually is in chronologic order. That's good. Oh, I like that. You may want to include more arrows. Just, I think it'll make it a little bit easier to follow. But otherwise, this is good. Yeah, I like this.
Thank you for the feedback.
Yeah, absolutely. Kevin, revised, born healthy, HPO at maturity, initial anovulatory cycles, after menarche, regular ovulatory cycles, luteal phase. Yeah, nice. Wow, this is great. This is awesome. It almost feels like you guys knew this, but I'm going to guess that you probably didn't. That's really cool. Nice. We're going to move on to our next one. This is going to be fibroadenoma. All of my cards are out on the table. I'm going to tell you what the summary of key concepts is. Pretty straightforward. It is that fibroadenomas, the etymology kind of explains everything that you need to know. We have referenced this in the past in our etymologies lecture, but as a review, fibro, it means fibrous. Adenoma means glandular, and then oma is a benign neoplasm. Benign meaning it doesn't invade, doesn't metastasize. Fibroadenoma means that it's glandular, well, it's fibrous and it's glandular, and that it's a benign neo. It's something that grows independent of the growth signal, but yet is not going to invade and or metastasize. And it's not surprising then that it's benign, that it's a neoplasm, and that it's of glandular tissue, and that it would be hormone sensitive. In other words, it's not surprising that that this would, I think particularly it's of the ductal tissue, and it's estrogen sensitive in a very general sense. And it's most common in the upper outer quadrant. This is just informed speculation, but this is presumably due to the fact that the breast tissue is most dense there. There are other possible explanations for this. This is just one, and I think it's a pretty convenient one. It also would explain why breast cancer is most common in the upper outer quadrant. Great, this is our vignette. What I'm going to do is I'm going to include the vignette in the Google Docs. I'll put this at the top. We'll start from the top for all of these. I'll put this at the top, and I'll put the text as well, that you can have the text. And then I'll put the summary of key concepts that you can work on applying these things. And as you're doing this, I want you to tell me, how do you feel about this? Am I giving you too much information? Are you guys like, oh yeah, this is making it too easy, I feel like I'm not learning anything from this? Or do you prefer this? Is this, this is a lot more pleasant or less unpleasant than just going in with knowing nothing and just stumbling in the dark? I'll give you several minutes to work on this, and then we will go over it. I am going to go over what I thought were the key concepts here. And I said the green stuff is basically just telling you that it's a fibroadenoma. The key giveaway is that it feels larger sometimes and smaller others. If it was cancer, then it would only get larger and should never really get smaller. Fibroadenoma is one of those things that classically will get larger as the cycle progresses, and then it will get smaller during menses and then start up all over again because of the hormonal effects of estrogen in particular. The blue stuff is the same as last time. It's anovulation first. You guys are picking up on this really well. Anovulation first because of immaturity of the HPO axis, and then eventually having ovulatory cycles. Initially irregular cycles, which almost always means anovulation. And then having regular cycles, which doesn't always mean ovulation, but often does. And this is just the cancer thing is just the obligatory thing to, because if someone has if a young girl or woman has a breast mass, you would be concerned about potentially cancer, or you have to just talk about family history. But the fact that this is like a relatively distant relative at a relatively old age to get breast cancer, it's not really concerning for something familial. And the yellow stuff is just describing the fibroadenoma. If you think about the etymology, it makes sense that it's fibrous and it's adenoma. And because it's an oma as opposed to a fibroadenocarcinoma, it is not a carcinoma because it's a fibroadenoma, meaning it's benign. It would make sense that it's going to be mobile. It's going to make sense that it's going to be relatively firm because it's going to be pretty high density because it's glandular and fibrous tissue. That would make sense. But it makes sense that it's mobile because if it's mobile, it means that it's not attached to something nearby. It means if it can move by itself, it means that it hasn't invaded in an adjacent structure. That would make a lot of sense. My pathophysiologic phenology, the summary is basically that you have a benign neoplasm of glandular tissue. In this case, it's ductal. It doesn't have to be. It could be, in theory, you could have it be in the glandular tissue itself, like the actual gland itself, like the mammary gland. But in this case, as far as I can tell, it's the duct and fibrous tissue. And it's most dense, which is going to be most dense in the upper outer quadrant. And it would make sense that you'd have a firm mobile mass that grows throughout the cycle and then shrinks with menses as the estrogen basically causes the growth of the ductal tissue and then will regress during menses when the corpus luteum regresses. Great. Let us go back to Andrew. Andrew, what would you guess? If you just had to guess the etymology of fibroadenoma, what would you guess it is?
Sorry, estrogen is stimulating the growth.
Etymology, meaning like the origin.
Oh, the etymology. Sorry, I thought etiology. Yeah, fibrous aden. I forget what the root for aden means. Oma is like growth or tumor.
Yeah, adeno means gland, and oma is its tumor. You are technically correct. Oma is tumor, but almost always oma refers to a benign neoplasm. If we say, let me think, fibroadenoma is a benign neoplasm as opposed to like pancreatic adenoma. Pancreatic adenoma is a benign neoplasm of the pancreas, of a glandular part of the pancreas. Pancreatic adenocarcinoma is a glandular cancer. It's a malignant neoplasm. Fibro technically means fiber. Adenoma is a benign neoplasm of a glandular tissue, adeno meaning gland. And Io, based on the etymology, what would you expect the histology to look like? Io, what do you think?
A lot of fibrous tissue and glands.
Yeah, pretty much. Yeah, that's pretty much it. And yeah, it's essentially a lot of fibrous or connective tissue and glands. And some of it, would you believe me, Io, if I said that some of the glands were open like a normal gland, but some of them were basically smushed? I think this is like a smushed gland because there's so much fibrous tissue that basically the gland gets like smushed closed.
Yes.
Yeah. You would also probably believe it that I'm not a pathologist. I use words like smushed. But yeah, that's basically it. That's basically what we're looking at. A bunch of fibrous tissue and a bunch of glands. That's it. Some of the glands that are smushed because there's so much fibrous tissue. Yeah, pretty cool. And next we have Edwin. Edwin, malignant. When we say it's malignant, cancer, rather than benign, what makes something malignant?
When you have invasion to the blood vessels,
Not necessarily just
when you have to make the basal membrane.
Yeah, exactly. Oh, very good. Exactly. Oh, you had me at invasion, but invasion of the basement membrane is even better. Great. Or there's invasion or what?
When you have decrease the calorie and you have increment of the fibronectin and intervene.
You're getting deep into the weeds and into things that you're just using big words now. Let's take a step back. Invasion is one of the things. There's one other thing that defines cancer. It starts with an end. It involves the term that Facebook just renamed their company into, metastasis. Invasion and or metastasis. You went one step further. You said invasion of the basement membrane, which is absolutely true. That is actually, I think, technically how malignancy or invasion is defined. That's really good. Great. And June, if a breast mass is fixed, meaning it's not fully mobile, would you be more or less concerned about that, and why?
More concerned.
More concerned, absolutely. Now, why is that? Why does that make sense?
Because I guess it's attached to the basement membrane, or I just remember whenever I see mobile and rubbery, that's like benign, and if it's fixed, it's
Sure. Yeah, exactly. You're absolutely right. It is more concerning. That is definitely true. If something's malignant, it means it can invade and or metastasize. And the idea is basically that if something is invaded, let's say that this is a benign neoplasm. You've got a neoplasm and it's benign, meaning it has not invaded the muscle. If I try to move this neoplasm, it's not stuck in the muscle. Do you think this is going to be this? Would you believe me if I said this is going to be relatively easy to move? Yeah, because it's just surrounded by like fat and breast tissue, right? Now, let's say that this is invaded into the muscle or a bone or something. If I try to move this, but it's like stuck or embedded itself into the muscle, how easily is that going to move?
Oh, that makes sense. Yeah.
It's not, right? And classically, what you're supposed to do is you're supposed to have the woman, like for if you're worried about like breast cancer, if you have a mass, what you should do is have them basically flex their pec. And in other words, immobilize the pec, make it contract. And because if the muscle itself has a neoplasm embedded in it, if it contracts, it's basically like latching onto the neoplasm. And if it doesn't move, especially when you are contracting the muscle, that's really concerning because it means that it's invaded into the muscle, essentially. Does that make sense? I'll show you a picture. Let me see if it's on the next arrow. You can see a picture. You can see how these borders are really well defined, right? It's really smooth. It makes sense that this is benign. It makes sense that if I were to try to move this, right? It's big. This is like a big mass. But it would make sense that you wouldn't I'd be able to move it relatively freely because it's not attached to anything. If this had invaded in a nearby structure, if I tried to move this, no dice. Does that make sense? Isn't that cool? The theme of our final core principle lecture was etymologies, right? It's pretty cool that you can basically predict the behavior of something, a fibroadenoma, just based on the etymology. Is it surprising that it's like dense and firm? Is it surprising that it's freely mobile? Is it surprising that because it's an adenoma, it's a glandular, that it would grow with estrogen and shrink without estrogen? All of those things make total sense. It's the power of concepts. It's the power of, in this case, etymologies. And let's move on to CAVN. CAVN is fibroadenoma benign or malignant. I think you said benign. Is that true?
Yeah.
Perfect. It's benign. Adenoma, benign neoplasm of glands. Adenocarcinoma means malignant neoplasm of glands. And CAVN, would a fibroadenoma be fixed or mobile? And I want you to use the etymology to explain why.
Fibro means fibrous, adenome means glandular, palma, like I said earlier, is like a benign neoplasm. So it's just benign neoplasm glandular tissue. Since it's benign neoplasm, it would be mobile since it's not attached to the basement membrane.
Totally. Boom, you got it. It's mobile. Yeah, it's a benign neoplasm. It won't invade or metastasize because it can invade. It shouldn't become enmeshed in the surrounding tissue and should be freely mobile. Isn't that cool? I love it. This is why I get up in the morning. Let us go to lady next. Lady, based on the etymology of fibroadenoma, how would you expect it to feel? And how would its size vary with the menstrual cycle?
I think if it's fibro, probably will be firm and throughout the cycle when the estrogen started increasing, maybe the size is going to increase because the glands are going to increase on size. And then when you menstruate, the estrogen goes down, then the size will go down.
Yeah, exactly. Yeah, that's exactly right. It's going to be firm because it's fibrous, like you said. I'm going to guess glands. I mean, glandular proliferation too, I'm going to guess is going to be pretty dense and firm. That would also make sense. It's mobile, like we discussed, as Kevin just beautifully described. And it's going to grow, like you said, with estrogen and shrink without estrogen. Like normal, breasts grow. The breast tissue grows with the different hormones. Ducts, more with estrogen. Glands, more with progesterone. In a very general sense, that it would make sense that hormones should cause growth of breast tissue. Yeah, isn't that cool? It just makes sense. Next, we've got Sahith. Sahith, in which quadrant does this occur most frequently? This we know is true. And then speculate as to why it might be true.
Probably the upper outer quadrant, just because it has the most glandular tissue.
Yeah, you got it. Yeah. It's the upper outer quadrant. Not clear why. We've got to resort in many places in life, as well as in medicine, we have to resort to informed speculation. And you don't know exactly why, but we do know that the upper outer quadrant has the most dense tissue. And so it would make sense that the area with the most dense tissue is going to be the place that has fibroadenomas more. Sophia, breast cancer. In which quadrant does this occur most frequently, and why would that make sense?
Would be the upper outer quadrant, and also because that is the area with the greatest density of glandular tissue, and glandular tissue responds to estrogen.
Totally. Yeah. Ooh, that's true. Yeah, that is true. Although also progesterone. Technically, I think the glands are more progesterone, but I'm gonna guess, like most things, there's gonna be overlap. Perfect. Wanchi, who gets fibroadenomas most commonly? Think about demographics.
The age range is like teenage years.
Yeah, that's right. Like younger women, basically teenage, like adolescents and women less than 30. And Wanchi, why would it make sense that it's most common in adolescent girls and women less than 30? This is just something that I literally used to memorize 3 weeks ago.
Is it because they have a higher estrogen?
Yeah, that is certainly one explanation. Yeah. Higher estrogen, I think that's true. I think that they have like more hormones. Yeah, I think that's probably true. We just have to speculate. I'm going to guess that part of it too is that they also have just greater breast tissue density. Like it's a matter of like, they've got more breast tissue and probably higher estrogen. And
Wasn't it also like during pregnancy also a lot of incidents with fibroadenoma? That's how I memorized it. Less than 35 years of age is how I memorized it from my OB GYN.
pregnancy too. Yeah, that
So
would
it's
fit
like-
very well with Wanchi's point that it's it's hormonally driven. That would make a lot of sense. There are certain things that we have to like that we know to be true. I actually didn't know that it was super common in pregnancy, but that is useful and that would make sense. We do know that breast tissue grows with estrogen. That would also make sense. Basically, like my thinking would be that in an even broader sense that the risk of getting a fibroadenoma or any sort of neoplasm period increases the more growth you have. If you have more tissue and or more growth signaling, that you would have a greater chance of having a neoplasm. But that would make sense. Yeah. Because as we discussed in our chronic inflammation lecture, anytime, this is not inflammatory, but in a general sense, every time you have cell division, you are going to make, necessarily are going to have mutations in the DNA, necessarily. And the idea would be that the more growth you have, the more cell division you have, the more hyperplasia you have, that the more mistakes will accumulate. And if you have more tissue and more estrogen, more signaling, then the chances of getting enough mutations to accumulate that you would have neoplastic, even benign neoplastic growth would be increased. I think we had a question.
Yeah, I'm sorry to interrupt, but it just makes more sense to me that the higher the density of breast tissue, the more likely it would to be malignant, because more tissue, more hypoplasia, more cell division is just more, it just doesn't click in my brain.
But which doesn't click? The fact that the upper outer quadrant, would it be like you could get malignancy with greater growth, or that you could get benign neoplasm?
The fact that you could get benign as opposed to malignant neoplasm based on that explanation.
Okay,
It just
sure. Yeah, that's an excellent point. I guess my question would be, how do you think you get a benign neoplasm in general? What do you think? What's like the general mechanism?
I guess for benign, there's more hypertrophy going on as opposed to for malignant, there's more hypoplasia and possibly hypertrophy. I'm sorry if I'm not pronouncing it.
That's okay.
American
So I think that there's probably some hyperplasia. If you look at the cells, they're generally larger. Most likely, like cancer would be associated with hypertrophy. I think that is true, where the cells themselves are growing larger. But remember the difference between as we talked about in our etymologies lecture, there's hyperplasia, there is benign neoplasm, hyperplasia versus neoplasm. The general definition difference is that hyperplasia means increase in cell number that is dependent on a growth signal in a very general sense. And a neoplasm is an increase in cell number that is independent of a growth signal. That doesn't mean that it can't respond to a growth signal. Like a fibroadenoma is growing on its own. It doesn't need the estrogen. However, if you give estrogen to it, it's like putting gasoline on a fire. But in neoplasm, you have both benign and malignant. And benign means that it does not invade or metastasize. And then malignant means it does invade and or metastasize. Okay.
Also, is
Yes.
like uncontrolled cell growth as opposed to this cyclic, it grows and then it regresses. It's not like an uncontrolled cell growth. Yeah.
Technically,
Like goes on.
neoplasm is an uncontrolled cell growth, like in general. Like you can get, have you seen, there are some like lipomas is benign. It's benign, but they can be huge, just gigantic. Technically, it's, how uncontrolled it is different. Technically, I think it gets down to, is it due to a growth signal? If I take away the growth signal, can it not grow? If I gave you EPO and you had an increase in this red blood cell number, erythropoietin causes red blood cell growth or technically that is hyperplasia, because if I take away the EPO, your red blood cells aren't going to just continue to divide on their own. In contrast, something like prolactinoma, right, OMA benign neoplasm, is something that it is increasing in cell number, even though there is no like growth signal, external growth signal. To get back to your original question, like why is it that I totally understand that increase in cell number or like a cell division process that causes accumulation of mutations would lead to a malignant neoplasm, but I don't understand why it would cause a benign neoplasm. They're actually just the same process. A benign neoplasm also happens to happen because you have an accumulation of mutations. Maybe it's that you have, it's called the hallmarks of cancer hypothesis. And if we look at the hallmarks of cancer, cancer is thought to have all of these different things for it to be cancer. It evades growth suppressors. It can cause genome instability and mutation. You'll have increase in telomerase or things that can allow it to replicate ad infinitum, that you have tumor pronate. Like there's all of these different characteristics, and these are all driven by genetic mutations, all or most of them driven by genetic mutations. And a benign neoplasm, you can think of it as being some of these, like fewer of these things, but still like the same ideas, accumulation of mutations. But it actually does, in my mind at least, make a lot of sense that a benign neoplasm would also be associated with times of increased cell. Does that make sense? Or did I not explain that real?
Yes, it makes a lot of sense now. I can see that my thinking was not correct. That it makes sense.
Great. It took me many years before I was able to differentiate between hyperplasia and neoplasm and all these things. Like I think it's fantastic that you're asking the question, because it is not easy, as you discussed, to get back on the horse. And it's scary, man. Like me facing up to all the things that I don't know or all the things that I feel like I should know. It's really hard. I applaud you for taking that step. It's admirable. For fibroadenoma, to get back to our summary of concepts, you can basically understand everything just from the etymology. It's fibrous, it's an adenoma, and it's not surprising that it's going to be firm, that it's going to be well circumscribed, it's going to be mobile, and it's going to grow with the cycle and then shrink when there's no estrogen. It's also not surprising that it's most common in the upper outer quadrant, and for the reasons that we discussed, just like with breast cancer, it's thought to be that there is just more breast tissue there, and it would make total sense that there would be an increase in cancer there. I'm going to give you guys another few minutes to remake or to revise your pathophysiologic chronology, and we'll spend a few minutes going over it, and then we'll wrap up. Great question. Your question was, with the first step in this case, in this particular case, would you ultrasound it first, or would you just do reassurance and more conservative, something more conservative? Probably more conservative. I think technically, like, you wouldn't just say, oh, it's nothing, I'm just going to send you out. Most likely what you would do is you would schedule like a follow-up at some point to come back in 4 to 6 weeks, and then we'll be assessed then. Yeah. In real life, probably people would do ultrasounds. I think people in general, have a pretty low threshold for doing ultrasounds, but I think the technical answer is that you would be reassurance and follow-up, close follow-up.
That would be like the Cuban USMLE answer. Because usually when they put a maternal grandmother or any family history of breast cancer, they want you to, I don't know, I'm a little confused or whatnot.
Yeah, the question really is the question is really, what would you do? Like, how would you, like, what's the USMLE answer? You have to be a little bit more discerning, though, when they're talking about family history. Like, someone that comes in where they've had their great-grandmother died of breast cancer when she was like 85 is not the same family history as, like, usually with family history, there's an age cutoff in almost every single case. Like, for example, colorectal cancer, the family history is considered, I think, a first-degree relative that has cancer before 60, or multiple second-degree relatives, or like multiple like relatives history. Right. In that case, you would do like early and frequent colonoscopies, for example. I don't know what the criteria is. I'm going to guess that one maternal grandmother who has breast cancer when she's 68 is not considered family history.
Makes sense.
Does that make sense?
Yeah.
Great. Let us go through and talk about your pathophysiologic abnormalities. I'm going to look at Sahith's benign neoplasm. Yeah, that's pretty much that. Like, that pretty much sums it up. Yeah, like, it's a benign neoplasm. You could even make that one thing, benign neoplasm, like fibroadenoma / estrogen. Like, it's amazing what you can do if you're really focused on the concept itself and you know what the words mean. It's amazing what you can describe with few words. Healthy, immature HPO axis, endometriation, ovulation, good. Yeah. Secondary sexual characteristics, great. Breast development, regularly since 13, felt the breast mass, good. Cyclic growth, Mass growth, cyclic in nature, probably estrogen dependent, grows during the follicular phase, regresses. I don't know if it's going to regress during the luteal phase. Remember, like you still have estrogen and progesterone. The two questions you ask, what's making the hormones? What hormones is it making? The corpus luteum is still making both estrogen and progesterone.
I think the only reason I said it was regressing was because I think I remember you saying that there's both, but progesterone levels would be greater than estrogen. So I think it would be a little bit.
You may be arguing like estrogen and progesterone oftentimes have antagonistic effects, and so that may be true. Honestly, I have a more simplistic view than I think you're taking. Just like estrogen is growth. But yeah, you're totally right. I don't know what the effects of estrogen and progesterone are. That might be true. And fibroadenoma, it's benign, it's mobile, it's firm, fibrous. Yeah, good. I like it. Yeah, that's nice. That's awesome. That's pretty much it. I'll show you what I said, but that's pretty much it. There's not like what you'll probably see with the OB vignettes is that they're not, the concepts, they're still concepts. They're usually pretty simple and straightforward. That's why I'm trying to make these shorter and that we can cover as many of these different sort of conditions as possible from a concept standpoint, because you don't really need that many concepts to understand this stuff.
I know that one of the things that you said in the beginning of the lecture was that estrogen is more for ductal growth, which is generalized. And I guess my question is, if fibroadenoma is mostly estrogen dependent and estrogen deals with ductal growth and that's more generalized, why is it like right upper quadrant versus being generalized?
It's an excellent question. And if you really want to go deeper into the weeds, there are papers that challenge the idea that it's like increased breast density. Like, it is true that the upper outer quadrant has more breast density. It is also true, if you just look at demographics, that there's more fibroadenomas and breast cancer in the upper outer quadrant. However, there are people that question that, the relationship between the two. Some people say, oh, maybe it's just because it's close to the axilla, and if there's like hormonal effects from, they say there may be hormonal effects from like deodorant. It's like, maybe that's affecting it. And I don't know. There's a lot of speculation. I think that would work too. Like deodorant.
Sorry, I was trying to like ask like some weird, but I was like,
it's a great connection. I had considered it. I did not come up with a good answer. If you find one, please let us know. Thank you so much. I appreciate the time that you guys took both to attend this as well as to give feedback on how to make this better. I love hearing ways that we can make this better for you. And I will try and really think about ways of doing that for this. Thank you guys. And I look forward to seeing you guys next time. Take care. The next thing that we're going to talk about is we're going to continue our OB lectures, and we're going to talk about abnormal uterine bleeding, which frankly was like the thing that scared me the most was the abnormal uterine bleeding. And we're going to start with our discussion with basically the PALM COEIN. I don't know how to say it, but it's the differential that you may have seen that helps you to work through the abnormal uterine bleeding. And I'm going to talk about different ways of thinking about abnormal uterine bleeding. The first way that I want to talk about actually is to think about the timing. We're gonna go back to the old way of, I'm not going to tell you the answer first. I'm going to show you the vignette and then I'll show you the answer because I want to see how that works again. But before, I just want to situate ourselves with thinking about abnormal uterine bleeding and talk about the timing. There's basically 3 different ways that you can see the timing for abnormal uterine bleeding in a very general sense. The first is you have regular uterine bleeding. It's just heavy. You get periods every 28 days. But when you get the period, it's really heavy. Classically, those would be things like adenomyosis, fibroids, or a coagulopathy, like von Willebrand's disease or something like that. The second, which we've already talked about, is irregular bleeding. Classically, that's anovulation, where you don't ovulate, you don't have a corpus luteum, and because of that, the follicle, the ovarian follicle, is just releasing estrogen. And the estrogen causes the endometrium to grow, and then at irregular intervals, you have sloughing of that endometrium and bleeding. But it's unpredictable bleeding. You don't have this regular bleeding. Classically, in almost cases, you're going to see that is going to be an ovulation in real life. And then the final case is what's called intermenstrual bleeding. That's where you have regular periods. Maybe you have periods every 28 days, but there's also this bleeding in between. That would be like polyp or endometritis or malignancy. Basically things where the bleeding is not necessarily dependent on the endometrial like sloughing cycle that you get with menses. I just want to situate ourselves so that we're not going in blind. I find this stuff to be very challenging, and I wanted to give you a little bit of information to think about before we do our vignette. So this is our vignette. I'm going to give you guys a few minutes. We've got a lot to cover today. I want to be timely because we have 2 vignettes to cover. What I want you to write is 2 things. What are the concepts that are being represented in the vignette, and what is the pathophysiologic? I'll give you guys a little bit of time to do that, and then we will talk about it. I'm actually going to end this here, largely because I am looking at what you guys are doing. It sounds like you guys are really struggling, which is totally what is like the thing that I used to struggle with a lot. And I wanted to give you guys this so that you knew that we experienced this. But yeah, there's no need to continue to have a lot of pain. Some of you guys think we're doing it, but most of you guys were like me in that it was a bit of a struggle. This is an endometrial polyp. An endometrial polyp, this is the summary of what it is that we're going to talk about, or summary of key concepts. An endometrial polyp is basically, we talked about hyperplasia versus hypertrophy versus neoplasia. It's hyperplasia. So it's endometrial tissue hyperplasia, usually extends into the uterine cavity, usually into the uterus. It can be in the cervical canal portion of it, but it's basically endometrial tissue hyperplasia. Classically, this leads to intermenstrual bleeding. You guys probably noticed she had regular bleeding, and then she had this spotting in between. This is intermenstrual bleeding. The mechanism of bleeding is not entirely clear from what I can tell, but it's like this generic irritation, quote unquote. I don't really know what's going on. Or my personal pet theory is that this is probably pressure ischemia, in that, I don't know, it's growing or it's pushing up against something and it's causing restricted blood flow and causing necrosis and bleeding. That's my personal guess, but irritation is a bigger. The other sort of factoid that you need to know is that there's a low risk of malignancy. Again, hyperplasia in theory can lead to neoplasia. Certainly. It wouldn't be surprising to see something like that where it could be malignancy. Anytime you see a growth, you could think of malignancy. But in this case, the thing you should know is that there is a low risk of malignancy. It's not zero. They will still take it out, but it is a very low risk of malignancy. What we're going to start with is actually PALM COEIN. Kevin, what is a common, useful way to organize the causes of abnormal uterine bleeding?
Like the timing of the bleeding?
This is like a read my mind question. This is like a leading question. Basically, it's PALM COEIN. This is all just an excuse for me to talk about PALM COEIN. The International Federation of Gynecology and Obstetrics, CIGO, which I assume is like French or something, which is why the letters are out of order, has talked. It's like when you talk about abnormal uterine bleeding, they have come up with a mnemonic, which is actually very useful. And the mnemonic is PALM COEIN. I don't know how to say the last part, but it breaks down into PALM, which is polyp, which is what this is, endometrial polyp, adenomyosis, leiomyoma, and malignancy. The first four things, the PALM things, are structural, things that you would see on imaging potentially, or things you'd have to do, or things you'd have to do. The non-structural things are the COEIN part. C is coagulopathies. That'd be like von Willebrand's disease, warfarin, stuff like that. Ovulatory dysfunction, like anovulation. Endometrial, which is interesting. Endometrial is, you would think it's like endometrial hyperplasia or something, but it's actually like the endometrium. It's like this kind of hazy thing where we think that actually that the endometrium isn't getting enough blood, or you can't vasoconstrict enough to cause a stopping of blood. But it's like almost impossible to prove clinically. It's like a diagnosis of exclusion and you can't really treat it. Like it's kind of this weird thing. It's almost like idiopathic is what I would consider endometrial. I is not idiopathic, which is what you would think it might be. It's actually iatrogenic, doctor caused, which I don't know. I actually would guess warfarin's a category, or N, which is really the idiopathic, which is. We're going to return to this continuously, and this will be a card that you guys have available to you. And this, hopefully, my hope with these series of lectures is to demystify there is blood coming out of the vagina and I don't know why phenomenon, which always gave me difficulties. Let's go to Sahith next. Sahith, abnormal uterine bleeding can use the FIGO classification to explain which would show up in imaging and or histopathology. Which would you need imaging or histopathology, or like endometrial pathology to figure out?
Oh, the structural or PALM, because it's something that's a problem with the way it's structured, but it probably will show up on the imaging.
Perfect. You got it. Yep. All the PALM COEIN categories, the PALM categories are the structural ones. Those are the ones for which imaging and or histopathology. It's useful to do this. I think one of the most useful ways to think about this is that PALM is really for older women. Like adolescents almost never have these problems. Cancer, fibroids, adenomyosis, polyp. Those things are things that happen as you get older. And it's useful because you can very quickly eliminate or put at very low in your differential if it's like a young girl versus if it's an older girl. Next, we're going to talk about timing. And next, let's go to Sophia. Sophia, generally for abnormal uterine bleeding, how can you think about the timing of the bleeding? What kinds of causes would the timing of the bleeding imply?
If it's at the end of the menstrual cycle, like close to day 28, you would think that it's due to menstruation. And although you can't necessarily imply that there's ovulation, like you might think that there's ovulation, therefore the menstruation. And then if it's like in the middle of the cycle or like not when you would generally expect the menses to be occurring, then you would think that there's like another cause for it.
How about if there's no regular pattern? In other words, there's two kinds of not every 28 days bleeding. There is the every 28 days bleeding, and then there's bleeding in between, which we call intermenstrual bleeding. Or there's just no regular 28-day bleeding phenomenon. Does that make sense? But in other words, like we just at the beginning, you can either have, right, the abnormal bleeding may just be because it's really heavy during menses itself, which you mentioned. You could have irregular bleeding. It's not every 28 days. It's, I don't know, one period that seemed like it was 5 days. And then the other day, then it lasted like 30 days. And then it was like 50 days. And then that would be an ovulation. But then the third kind is, which is we saw here, is intermenstrual bleeding. You have regular bleeding every 28 days. But then you have this, you have spotting, you have some sort of bleeding in between that. Does that make sense? Again, I find this stuff very difficult. This is why I'm going to repeat this stuff many times, because I think it's important to reinforce. Matthew, we've got a 39-year-old woman comes to the physician with abnormal uterine bleeding. First of all, the fact that she's 39, what does that tell you about the likely causes of this? Is PALM higher on your differential or lower on your differential?
Good question. Let's see. Polyp, adeno. I would say I'm accustomed to seeing adenomyosis in a 40-year-old middle age. Leiomyoma is also like middle age. I would say it's probably higher.
Yeah, exactly. In other words, the PALM things, right, the structural things are things that you would not expect in someone that was young. But anyone that's not adolescent, sure, like rises up your differential. 39-year-old, not old, she's not old, but she is not adolescent. She didn't just start having periods. And so, yeah, that would definitely, PALM would definitely be higher. Great. She reports that she has regular periods every 28 days, lasting 3 days at a time. That's normal. However, she notes that between her periods, she is spotting with wiping. So what kind of abnormal uterine bleeding is this? Which category of the timing would this be?
Yeah, intermenstrual bleeding.
Very good. Yeah, exactly. What kind of timing?
Would I be able to ask a quick question on this one?
Please.
What's strange is, especially on QBank, they have this distinction between like there's like normal bleeding versus like normal physiology versus abnormal like pathology. What I mean is, even in pregnancy, lochia is like normal. Like when you deliver a fetus, at what point does that become pathological? And similarly, if you see a question with bleeding in between periods, how can you be certain that's actually intermenstrual bleeding versus just like a benign normal variant of bleeding? You understand my question?
Can you think of a normal variant of bleeding?
What I mean is, like, I don't know, because maybe I don't know enough about the menstrual cycle too. Because maybe for someone who knows about the menstrual cycle, maybe like that question would be stupid. But for like, let's say my background is the only thing I know is that you have ovulation and you bleed during ovulation. That's the only thing I know. Then how would I know that your intermenstrual bleeding is?
You wouldn't.
I guess I'm asking a bad question. Yeah. Okay. It wouldn't know.
How could I predict, like, how could you have predicted that you might get a little bit of bleeding, like vaginal bleeding after giving birth? How do I know that's not normal? You don't. That's the thing. You don't. That is something that you do. I wish I could have predicted that, but in retrospect, I can explain it. Yeah, you just had baby going through the birth, like your cervix and the vaginal canal, and yeah, it wouldn't be so surprising. But would I have been able to predict it? Nah, probably not. No.
It's just, yeah, that was my question. Is like, there's always like benign normal variants. I was just making sure it's always pathological, even if it's like minimal bleeding. It's pathological if it's intermenstrual.
Yeah, because in this case, like normal uterine bleeding is like regular. There's a specific duration. There's a specific amount. I think it's about 3 to 8 days or something. It has to be a certain amount. They have like a certain number of milliliters, and it shouldn't be like shouldn't have to change your pad more than every 2 hours and blah blah blah. There's like a list of things. Now that we've covered that, I wanted to talk about the concepts. What were the concepts that were being discussed? The green stuff here is intermenstrual bleeding, as we just discussed. All of this blue stuff is really just saying that there's no obvious pathology. We'll talk about this later, but like the bimanual exam is a big differentiator between the structural causes and polyp. You can't tell in a bimanual exam. Adenomyosis, you can, right? It like classically, it's a symmetrically enlarged uterus. And the bimanual exam is really important. Leiomyoma, those are, if they're big enough to cause bleeding, they should probably be big enough that you could feel them, presumably, right? In these vignettes, they would. You get this irregularly shaped uterus, and then malignancy you wouldn't be able to see on an exam. And there's no obvious pathologies here. And the yellow stuff is just showing you an endometrial polyp. Oftentimes they're pedunculated. Again, it's a hyperplastic growth of endometrial tissue. And within the uterus, so hysteroscopy, hystero is uterus. Hysteroscope is you're looking at the uterus, you're visualizing the uterus. And you see a pedunculated, smooth mass with sparse intracavitary bleeding. In other words, you see a little bit of bleeding, evidence of the bleeding from the polyp, and you will see the polyp. That's what they show. Great. What's the pathophysiologic chronology? This is the pathophysiologic chronology. And actually what I'm going to do is I'm going to copy this. So you guys can have this in the Google Doc itself. And then we're going to do what's the pathophysiologic phenology. Again, the summary, and this is really important that you guys have the summary, because the summary forces you guys to not only identify what the concept is, try to simplify it so that you can understand it better, but also this is making it easier on your future selves so that the review goes faster. My summary would be there's non-malignant growth of endometrial tissue, thought to be hyperplasia. That leads to irritation versus maybe some pressure ischemia, and that leads to intermenstrual bleeding. Fundamentally, that's it. You get this thing that grows, it pushes up on something, maybe that's going to cause pressure ischemia, maybe it's just the irritation that they talk about, and that is going to cause bleeding in between the periods, but it's not going to disrupt ovulation. You're still going to get the more detailed version is basically that, basically just that. I go into a little bit more depth. Great. Jeez. Yeah. Let us go to Andrew. Andrew, what is a polyp?
My memories of polyps are mainly seeing them removed, but it does cause the bleeding.
But
I
just
think,
generally,
like we
what,
touched on.
very general.
It's like a growth of the uterine tissue, and there's a different classifications for what layers it
In a
occupies.
general sense, so a polyp is just an abnormal growth of tissue projecting from a mucous membrane. Abnormal growth of tissue, I think most people would have gotten. Mucous membrane is something that I actually didn't know, that a polyp came from a mucous membrane. Edwin, based on the definition of a polyp, could this be cancer, non-cancer, and why?
It can be both
Yeah. Why does that make sense?
because it can be a normal growth tissue. Probably depending on how many mutations have that tissue, can be a cancer or it can be no.
Perfect. Yeah, exactly. Yeah, great point. Cancer, the more mutations you have, the greater the likelihood of cancer. If you have fewer mutations, maybe it's benign, maybe it's just hyperplasia. And the polyp is a general term. It just means that there's an abnormal growth of tissue from a mucous membrane. Abnormal growth could be neoplasia, could be hyperplasia. And there's nothing about a polyp in and of itself that says that this must be cancer or not, which is why they always take them out when they do a colonoscopy to see. Great. And let's go back to Kevin. Kevin, what is an endometrial?
Normal growth in the endometrium.
Essentially, yeah, that's pretty much it. Abnormal tissue growth in the mucous membrane of the endometrium. Great. That was fantastic. Yeah, exactly. Go ahead. What is the proposed mechanism of causing bleeding for endometrial polyp? Which, granted, we don't really know, but what would make sense?
I think with endometrial hyperplasia in the beginning of the menstrual cycle, it would probably be endometrial hyperplasia, and then the demand will be more than supply, and it will then cause sloughing and then necrosis.
Oh, I didn't even think about that. Oh, because I was thinking pressure ischemia, but I really like that. Yeah, I said rubbing against the right tissue with necrosis, exposure, or underlying blood vessels. But I like yours. The alternative, maybe, right? Alternative would be that you have overgrowth of tissue, which leads to demand greater than supply. That leads to ischemia.
Which is what I thought was estrogen dependent things would cause increased risk of polyps.
Ooh, interesting. So that would be a separate thing. That would be a separate explanation. But that would also be, because again, estrogen. This is good. Man, look at all these connections. Boom. Nice. That's really good. Let us go back to Sophia. Sophia, endometrial polyps, based on what it is, would this affect ovulation? Is this going to stop you from ovulating? Why or why not?
I don't think it would affect ovulation because you still have, I'm thinking, yeah, it wouldn't, because with ovulation, I don't see how it would interfere with the maturation of the ovarian follicle and that whole process.
Yeah, you got it. Yeah, it shouldn't affect it. Yeah, there's no reason that you would expect it. Therefore, yeah, it's just an abnormal growth of endometrial tissue. Why would that affect the follicles, or the ovaries, or the HPO axis, or any of that stuff? It shouldn't, right? And take it home then. Sophia, can you explain endometrial polyp versus anovulatory bleeding? How would the bleeding differ classically, and why would that make sense?
With anovulatory bleeding, you still have endometrial hyperplasia because you still have the estrogen being produced from the ovarian follicle. You just don't have the luteinization. So you still have the endometrial hyperplasia, and eventually that outstrips the blood supply. You have ischemia, you have the sloughing of the endometrium, and you get bleeding. And for an endometrial polyp, yeah, I'm not sure I know how or why it would differ. Both lead to intermenstrual bleeding is my understanding, but I'm not understanding.
So endometrial polyp leads to intermenstrual bleeding. Anovulatory bleeding, would that lead to intermenstrual bleeding?
That would lead to, I think I'm still having a hard time understanding the difference between.
So intermenstrual bleeding means you bleed regularly every 28 days. But in addition, sometimes you bleed in the middle of the every 28-day cycle.
Okay, I see.
Truly irregular, well, I don't think they call it irregular bleeding, but it's what it is. Truly irregular bleeding that you get with anovulation, it doesn't follow, there's no discernible pattern.
I see.
Does that make sense?
Yeah.
This is, it's just because you get more and more estrogen, as you said, hyperplasia of the endometrium. Eventually, it's going to be too much demand for too little supply. But how long it takes is not going to be a set amount of time. You're going to get overgrowth of the endometrium and cool.
One of the questions I had about that is you wouldn't be able to tell just based on the pattern of bleeding whether it's an endometrial polyp or anovulatory bleeding. Would you be able to without doing like the imaging and such, or just like more?
Generally, anytime that you have bleeding that takes like too long of a cycle, you should, right? Because that would be anovulation. Let's say that you have some cycles are 28 days, some cycles are like, sometimes it was like 45, some is 2 months. That is anovulation, because I can't think of a way in which like a polyp suddenly cause like a 60 days. That's not really a cycle at that point. I think what you're asking is if you have intermenstrual bleeding versus like relatively regular anovulatory bleeding, is it possible that you wouldn't be able to tell? Yeah, I guess, frankly. Yeah. If you had bleeding every 28 days, but in addition, sometimes if you had bleeding 5 days after the last cycle, sometimes it would be like 60 days after the last cycle. Could that look like anovulatory bleeding? Maybe. But my guess is that you would still be able to tell a pattern. I don't know. I'm not an obstetrician, but my guess is that like the bleeding of a polyp is not going to be as profuse and regular as the bleeding of like your menses.
I saw some cases during my rotation where if patients, they accumulated multiple polyps, depending on the size, the bleeding actually would be quite profuse.
That's fair. Yeah, maybe. Yeah. Again, can you note just from the history? I guess the question is this: would you be comfortable treating your cousin with just knowing just the history without anything else? Probably not. Yeah. But I think generally, certainly in a QBank question, I think you should be able to tell, because they'll tell you happens every 28 days, but then you get this intermenstrual bleeding. Matthew, did that answer your question, Sophia? Like a non-answer.
Yeah, it did. Thank you. That clarifies it. And yeah, the definitions really help, because I think I was still mixed up on that.
Perfect. Matthew, endometrial polyps, based on the proposed mechanism of bleeding, can you explain whether the bleeding would be only during menses or between menses, and why?
So a polyp, I imagine, is between menses because it does not directly affect the ovarian follicle shedding. I imagine it's in between.
You got it. Perfect. Yeah. Exactly. And your reasoning was very solid. That was great. Yeah. Great. And that was it. This is endometrial polyp. Endometrial tissue hyperplasia extends into the uterine cavity. You can read the rest of the summary of concepts that are put into the Google Doc. And yeah, that's it. I'm going to end that here so that we can move on to our next vignette. Before I do, though, any questions before we talk about our next vignette? Excellent. Here is the next vignette. I will put it in the Google. I'll put it at the top, just like I did before. I'll read it just for those of you who listen to these things in the car or something. A 43-year-old G2P2 woman, gravida 2, para 2, woman comes to the physician for evaluation of painful menses. Menarche was at 13 years old. Current menses occur every 30 days. Previously, bleeding was moderate and lasted 4 days. However, over the past year, she notes heavy flow for 5 days with pain unrelieved by ibuprofen. That's a sign for bad pain. During the first 2 to 3 days of menstruation, the patient changes her tampons every hour. She has 2 prior C-sections. By manual exam demonstrates a soft, symmetrically enlarged uterus, which is temperature palpation. Her urine pregnancy test is negative. I will have you do 2 things. I want you to write the concepts. What do you think the major concepts are that we're discussing? And then I want you to write the pathophysiologic chronology, including the summary. Work on that, and we will discuss it in a few minutes. This one went a lot better. I think that a lot of you guys got it. I intentionally tried to do 2 back-to-back of the same sort of variety that you could learn the PALM COEIN and then apply the PALM COEIN. That was good. This is adenomyosis. Basically what it means, what adenomyosis is, you can use the etymology. Adeno is gland, myo is muscle, and then I think os is like process or something. What it means is that you've got abnormal adeno glands in the muscle, abnormal location of the endometrial tissue within the muscle, within the myometrium. That's associated with then hypertrophy or hyperplasia of the myometrial stroma, the connective tissue part of the myometrium. The classic presentation is basically what we saw here. You get dysmenorrhea, right? Secondary dysmenorrhea. In other words, it's not like secondary dysmenorrhea means that it's secondary to, it is caused by some sort of pelvic pathology, in this case, adenomyosis, which again makes sense because you have literally menses into the uterine muscle itself. That's insane. I cannot imagine. Menses itself seems pretty painful. Oh my gosh, if I was into a muscle, like I can't imagine. Because you have the endometrial tissue that grows into the muscle, and then the subsequent hypertrophy and hyperplasia, that leads to symmetric enlargement of the uterus. And that's why there is the big uterus all over. And there may or may not be uterine tenderness. Presumably, it's going to be tender during menses because, again, you're going to have bleeding into the myometrium, which is going to be inflammatory. And then when you have anytime you have inflammation, basically, you're going to have tenderness. It's unclear what the etiology is. May involve endometrium being introduced into the myometrium. But like it's associated, you'll see in like classic texts, they say it's associated with uterine surgery. There's, if you read primary literature and stuff, like it's maybe not quite clear, but yeah, like a very tantalizing possibility would be you cut into the uterus, the endometrial tissue gets into the myometrium somehow, makes this in, or maybe there is some overgrowth of the endometrial tissue into the myometrium itself. We're going to talk about all this stuff, but that is the summary of where we are going. Remember, we just talked about PALM COEIN, and the PALM stuff is the structural stuff, Polyp, adenomyosis, which is what we just did. We did the first two, also leiomyoma or malignancy. And again, you can see how it's structural. You can see, again, Sophia, the PALM ones, are they, who would you expect to see them in? An adolescent or someone that is not an adolescent?
And people who are not adolescents.
Exactly. It is not surprising that this woman is 43 and has had multiple C-sections, because again, the thought would be this is something structural. Again, this is not the kind of thing that you see in adolescents. And the fact that she's had the C-sections, again, is that like they're cutting the uterus. Who knows? Maybe there's like endometrial tissue that somehow gets into the myometrium somehow is a thought. Then we've got the COEIN stuff, coagulopathy, ovulatory, again, ovulation, endometrial, which is the weird one, which is you can't constrict the blood vessels well enough, so it just keeps bleeding uncontrollably, iatrogenic, which is we caused it, and then non-neoclassified, which is, I guess they were trying to come up with something that started with an N that was, but they wanted to say idiopathic. Great. Kevin, generally, how can you think about the timing of the bleeding for abdominal uterine bleeding? We just talked about this. What are the kinds of causes that you would expect for the timing of the bleeding? What would it imply?
There's bleeding during the menses, and they still have regular menstrual cycles. That implies like fibroids or adenomyosis. And then there's bleeding during or in between the menstrual cycles, and that would imply for a younger woman like anovulation, or for an older woman it would be a polyp.
I'll be careful. Those are actually two different things. Remember, there's irregular bleeding. There's no clear pattern. And then there's intermenstrual bleeding, which is, there is a pattern, but there's also these like unexplained episodes of bleeding that you get in between regular periods. Which is which? So if it's truly irregular bleeding, some cycles are like 60 days, some cycles are 45, some are like, I don't know, 20. What would that be?
That would be anovulation.
That's anovulation. Great. For anovulation, right, that's truly irregular bleeding or endometrial hyperplasia. How about intermenstrual bleeding? What would that be?
That'd be a polyp, because it doesn't affect the ovulatory cycle. You'd still have regular menses.
Boom.
But the polyp would still induce like pressure ischemia or irritate the endometrium and lead to bleeding between the cycles.
Oh, look at you. Yeah. Or malignancy, or great. This is really good. You guys know way about this than I did at basically any time of my medical training. Next, let's go to Andrew. Andrew, 43-year-old woman, GGB2. Menarche was at 13. Now it occurs every 30 days. Previously, it was moderate and lasted 4 days. However, over the past year, she notes heavy flow for 5 days and pain unrelieved by ibuprofen. What kind of timing for the abdominal uterine bleeding is this?
Yeah, this is dysmenorrhea. It's with the menses, just this like abnormally painful and heavy.
Yeah, perfect. Yeah. Let's be careful though. Dysmenorrhea technically means what?
I think the term refers to like painful menstruation.
Yeah, she does have dysmenorrhea, that is true, but the bleeding aspect of this is actually referring to what?
Let's see. It's referring to the AUB.
Yeah, exactly. She has not only secondary dysmenorrhea, but she also has AUB, abdominal uterine. Just so you guys know, they used to call this dysfunctional uterine bleeding, which I think dysfunctional uterine bleeding, which just sounds offensive. They changed it. Now it's just abdominal uterine bleeding. But yeah, if you see the like dysfunctional uterine bleeding, then yeah, that's a no. We don't say that anymore. Yeah, exactly. This is just this is a heavy menstrual bleeding. Regular menses, it just happens to be really helpful. Really heavy bleeding timing is to make that really clear. Great. Matthew. Well, I'm just going to describe this first, and then we'll go to Matthew. But we have, again, the green stuff is really telling you about the secondary dysmenorrhea. This is the painful menses. Let's be very clear. This is painful menses and abdominal uterine bleeding are potentially related, but not necessarily. They're two distinct concepts. And so the fact that she's got pain that's unrelieved by ibuprofen is probably twofold, frankly. It's probably the fact that, anytime you have pain that's unrelieved by blah, 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 really what they're trying to tell you is like, how bad is it? If you tell an anesthesiologist or a pain doctor, hey, I have pain, they're going to, one of the next questions they're going to ask you is, what have you tried for it? And so they're going to try to get a sense of like how painful it is based on how much the pain meds are. Because just saying, oh, it's 7 out of 10 is like useful, but it's very subjective. But saying ibuprofen doesn't make it better tells you this is pretty bad. And second of all, it's also telling you that it's probably not primary dysmenorrhea, because primary dysmenorrhea, the mechanism is, again, Edwin, what's the mechanism of primary dysmenorrhea?
Prostaglandin.
Boom. Yeah, exactly. Yeah. And two, hypersecretion of prostaglandin. And if ibuprofen doesn't work, that argues against the idea that this would be primary dysmenorrhea, because again, ibuprofen should block the prostaglandin mechanism, the synthesis of the prostaglandin. The blue stuff is really telling us about the regular menstrual bleeding. This is the abnormal uterine bleeding. This is regular menstrual bleeding. It is every 30 days, but it's just really heavy. And then the yellow stuff is telling you about the adenomyosis, which is the 2 prior C-sections. Maybe that's getting at the endometrium went into the myometrium. And then you've got the bimanual exam. You've got, instead of it like what we had before, where it was a small uterus, you couldn't feel anything. You could only, when you took a camera and you looked in the uterus itself, could you see the polyp. In this case, just feeling the uterus, you're like, oh man, this is big. And it hurts when you touch it. It's tender, which again makes sense. If I'm bleeding into the muscle of my uterus, that's going to be painful. Our pathophysiologic chronology is what we just discussed. She has multiparity and C-sections, which both are associated with adenomyosis. She gets adenomyosis, and then you get a symmetric enlargement, secondary to dysmenorrhea, because you're bleeding into the myometrium, and you get heavy menses. And we are on Matthew. Matthew, what's the etymology of adenomyosis?
Glandular growth in the myometrium.
Yeah, very good. Boom, look at that. Yeah, exactly. Or I guess osis is condition, but yeah, I was the one that messed you up. I said this was ios muscle, and then osis is condition. And take it home, Matthew. Based on the etymology, what is it?
Oh, I would say it's growth of some type of, I don't know how else to say it. It's like some abnormal growth of glandular tissue in the muscular layer of the uterus that normally does not grow there.
Perfect. Which glandular tissue
causes that? Oh, which glandular? Yeah, I'm not sure. Like, you mean what cell type or?
I think the natural response when someone asks you a question that's like histology, especially since step 1 was so long ago, our initial thought is to think, oh my gosh, this must be something I don't know. And immediately go to the hardest thing you can think of, which is like, what cell type would it be? Which is like the hardest question I could possibly imagine. What cell type? No, it is actually a simpler question that I'm trying to ask. I'm just not doing a very good job of asking it. Is it endometrium? Is it coming from the serosa? Is it coming from like the ovaries? What glandular tissue? Is this pancreatic glandular tissue? What tissue are we talking about?
Oh, yeah, that's a good question.
I think you're overthinking.
Well,
would you believe me if I told you?
I'm not sure. Is it endometrium? Oh, it's in the endometrium.
It's just the endometrium, the inner lining of the uterus, grows into the muscular layer of the uterus.
Yes.
Make sense?
Yeah.
Yeah. It's basically like the endometrium, like it's almost like it invades it. I shouldn't say invasion because that makes it sound like cancer and stuff, but like it's kind of like invasion, frankly. Again, adenos gland, myos muscle, and then osis is condition. Great. Let us go to Sophia next. So Sophia, adenomyosis, how painful is this going to be? Why would that make sense?
It would be painful because you usually have growth of the endometrium throughout the menstrual cycle. And as you have like the hormonal changes, like estrogen increase, you would have that endometrial tissue that is within the myometrium increase as well. And then I would suppose that would cause pain. And then when you have the menses, you would have bleeding in between the myometrium, which would cause like pressure and inflammation and pain.
Yeah. Exactly. Yeah. I don't know that I can explain that better. Yeah, exactly. It's growing. I never thought about it that way. Yeah. Not only is it growing, which presumably going to hurt because you're like expanding like within this relatively enclosed area. But in addition to that, you're going to bleed into the myometrium, which, gosh, menses already is like pretty bad. I cannot imagine what it would be like to bleed into the muscle. Jeez. As a general thing, if you want to read more about this, you can look at this reference here, but blood is very irritating. And in terms of, I always knew that. I never knew why. And I was looking this up. And partially it's thought that this is because of the free iron containing heme. So heme obviously has iron in it. And that iron can cause free radical damage. And I have this saying, yeah, this is giving me compartment syndrome vibes. Yeah, it's like compartment syndrome. Not only is it like growing into the compartment, but then in addition to that, you're like bleeding into it, which is also like compartment syndrome. You've got like this enclosed space. And yeah, like that's just going to hurt. And in addition to that, blood itself, because of the iron in the heme, can cause free radical damage. And this vague membrane disruption thing, which I mean, makes sense. Yeah, makes sense, but that is going to be. Sahith, for endomyosis, might you expect that there could be uterine tenderness? Why or why not?
Yeah, I think just because I think it'd be, I was thinking artery capillary vein is when maybe there's decreased blood supply. If it's growing out and it's compressing the vessels around it, then there's a chance of there being artery capillary vein, compress the arteries, decreasing capillary blood flow, and then the ischemia, which leads to necrosis, leads to pain.
Oh, interesting. I didn't even think about that. Yeah, I mean, you could, in fairness, like tenderness is usually a sign of what process? If you come in with chest pain and I push on your chest and it hurts.
Oh, I'm sorry. Yeah.
Inflammation. Yeah. Generally, if you see tenderness, I'm sure you can think of like exceptions, but like generally that is pretty indicative of inflammatory process.
Yeah. Yeah.
Like, I think that, would you believe me if all the free radicals and all the other mechanisms that you just said, like led to, in addition to necrosis and compartment syndrome, like physiology, which again, I don't know if that's true, but I wouldn't be surprised. Would you not be surprised if there would be inflammation as well?
Yeah. Yeah. It totally makes sense. Because I think it's every time you think like free radicals, you think like cytokines, and the cytokines lead to inflammation.
But like the soup of, like cytokine storm and something's happened. I don't really know, but it sounds really good it's like cathartic to say cytokine storm.
Oh yeah, the hand wavy explanation.
Talk about the risk factors for adenomyosis.
Heavy bleeding.
That's what it leads to. Risk factors, means what can lead to, in whom would you not be surprised?
Multi-pregnancies.
Perfect. Multiparity is a big one. What's the other?
High level estrogens.
That's interesting. I think that's probably true. Yeah. That's actually, I think, one of the reasons. That was actually one of the reasons I think why multiparity was thought to potentially lead.
Contraceptive pills.
Again, disputed, and I had to look them up. The classic ones that you'll see like in New World are like older age, which again, PALM, that's like a given. Any of the PALM ones are going to be older age. Multiparity, like you said. And then the big one, the one that I find most interesting, although in fairness, this is disputed, but one of the ones that I found was uterine surgery.
I have a question, Dr. Alec. Do you can see a high inflammatory process in this condition?
I would think so. This is just a conjecture though. And that's a conjecture just because I know that blood is very irritating, which heme causes free radical damage. Any kind of damage is going to lead to inflammation, period. B, I also know that you can get uterine tenderness with adenomyosis. And that would be the most obvious reason why would be inflammation. What I don't know is, I think that I would argue that the inflammation is probably secondary to the actual disease process. What you may be asking is, does inflammation lead to adenomyosis? And that I don't know. I wouldn't be surprised, but
you don't see high level interleukin 6, interleukin 1 in this kind of condition, or you can.
Yeah. Do they have like fevers and stuff? Probably not. I don't think it's like systemic. But I don't know. You sound like you are like have a research mind. A good question. I don't know. It's a really interesting question. I don't know. Kevin, for adenomyosis, based on what it is, can you explain what the risk factors are? Older age above 40, multiparity, and prior uterine surgery. Why would they make sense? Why do these risk factors make sense?
There's like constant damage to maybe the endometrium, or there's like excess endometrial growth, and it could extend into the muscle layer.
Yeah, that was what I was thinking. Yeah, exactly. And basically the age thing makes sense because again, like the older you are, like the more likely it is that the more likely that any of these processes could happen. Multiparity, one thought was that, like what Edwin said, that there was more estrogen being produced, and because of the more like higher levels of estrogen, you have higher levels of estrogen, you're going to have more endometrial growth. The more endometrial growth, then maybe that's going to somehow invade into that. I think what Kevin, you were getting at was like, if you have surgery, then maybe you can have a mixing of the endometrium with the myometrium. If I'm cutting into the uterus, I'm cutting the muscle, and I'm going to cut into the endometrium. If they are, depending on the stage of where the endometrium is, who knows? Maybe the endometrium, some of those implants like get into the myometrium. That's how it goes. This is thought to be, again, no one knows exactly why endometriosis happens, but this is one of the leading hypotheses for what endometriosis is. You get endometrial tissue that kind of sloughs off and then somehow starts growing somewhere else. It's not too hard, if you believe that is possible, it's not too hard to believe that if you had some endometrial tissue, if it gets on the ovaries, it's going to grow there, and that's endometriosis. But if you get a little bit of endometrial tissue and it gets into the myometrium, into the muscle itself, that it could just start growing. Not hard to. And next we have Andrew. Andrew, this is the two ways that you would image generally for adenomyosis is MRI or ultrasound. So this is MRI. And Andrew, based on what it is, would you expect the uterus to be smaller or larger? Would this be symmetric or?
There's extra stuff in the myometrium should be larger, and the classic looking at is that it's like a symmetrical enlargement versus something like endometriosis. It's like asymmetrical, irregular.
Maybe not endometriosis. Maybe endometriosis would be. Well, what's the classic asymmetric enlargement that gives you abnormal?
Or fibroids.
Fibroids, exactly. Boom, you got it. Yeah, exactly. But yeah, someone has like secondary dysmenorrhea and abnormal uterine bleeding, heavy menstrual bleeding. That could be adenomyosis, that could be fibroids, depending on what the uterus feels like, depending on the imaging, can help you figure out which it is. Certainly in a question, and I think also in real life too. Great. And yeah, my myometrium is throughout the entire uterus. Makes sense. Makes sense that the uterine enlargement would be symmetric. Great. But next we've got Matthew. Matthew's based on the imaging findings, MRI or ultrasound, would you expect the bleeding to be heavier or lighter than normal? And why would this make sense? If it's a
First of all, I'm really bad at reading images. Not sure how much the image helps me, but you obviously expect it to be heavier because you're growing this gland from the endometrium into the muscle. And there's so many blood vessels in the uterus. There's like a uterine artery, for example, and you compress this, obviously you're bleeding. It could have been a donut. It could have been a foreign body. It could have been albuterol. It doesn't matter what it is. You push it on the blood vessel and it bleeds.
Yeah, I like that thought. And actually, more than the artery, I actually really like your thought, particularly for the veins. Because if you compress a vein, then because this is thought to be one of the reasons why like fibroids bleed more, is that they're bulky. They're going to push on the venous return. If they push on the venous return, you're going to have backup of blood into the capillary. The capillaries are really engorged. If they start to bleed, the bleeding is going to be heavier. Yeah, that actually makes a lot of sense for adenomyosis. The thought that they have given for adenomyosis for why is that because there's so much enlargement, that there would be a larger surface area. But I like your explanation in many ways even more, because that's true. It is huge. And I'm with you with the I can't read images. I'm certainly not MRIs. If I included a normal uterus, this is normal uterus. This looks like T2 because the fluid is white. This is a normal uterus, and this is the adenomyosis uterus. It's huge. This whole thing is like an enlarged, looks like the anterior posterior wall, right? Because this is the spinal column. And this whole thing is like the posterior uterus. I think this is probably the uterine cavity because it's white, and the fluid is probably T2 because this stuff is white. And then this is like the anterior uterus, I think. I'm not a radiologist, but yeah, that makes a lot of sense. And I think next up we have adenomyosis. Based on the pathogenesis, explain the classic presentation and why would that make sense?
I'd probably just say it has menorrhagia, super enlargement, and compressing the backflow from the veins to the capillaries, a lot of that blood loss. And then it would have some menorrhagia and then dysmenorrhea just from the dysfunctional bleeding. You don't know when it's going to come and when it's going to go. And yeah, I think those are the two major things. And it'd be uniformly enlarged from outpatient's like side, from the outside, it'll be uniformly large, like lobular sort of swelling.
Yeah. I'm not sure though, like not sure when it's going to come and not sure when it's going to go. I guess that kind of makes sense. Yeah. But when is the pain going to be worst?
Probably it'll probably be during, honestly, like earlier menses when there's increased estrogen, because that'll cause the growth of or just be more pressure. There'll just be more, it's like more hyperplasia and stuff.
Like, I think you're naturally being drawn towards, when in the menstrual, I just meant like during menses. Menses, just the menstrual period, the menstrual cycle, like the menstrual portion of the cycle is going to be the most painful one. Because again, that's when you're bleeding in. I don't know, it's going to be beginning of menses probably, but yeah, that's beyond what I was asking. Again, it's funny. There's like this general phenomenon. I do it too, where and this is definitely relevant to your question. You get a question on something that you are not like, that I'm insecure about, that I'm not certain about. And if I write down my standalone question, if I write down my concept that I think that it is, oftentimes I think that the questions they're asking is much easier than it is or much harder than it actually is.
It's probably much easier than it actually is.
I think it's much harder than it is, but the question itself is a lot easier. This is an example of this. This wasn't intentional, but I think this is an example. I don't know. This is a general phenomenon where I will oftentimes think that the question that is being asked is much harder. And I find that's particularly true if it's something that I'm less secure about, that I'm learning.
Yeah, that's fair. And I have an example for that if you have time at the end.
Yeah. Maybe. But it's definitely common. Great. Secondary dysmenorrhea. Again, not saying like early part of the period, later part of the period, just painful periods, heavy menstrual bleeding, and the diffuse uterine enlargement. Those are the classic things. I guess the other thing that would add to that is plus or minus uterine tenderness. Again, tenderness, sign of inflammation. Makes sense. Adenomyosis, again, have we talked about that? Yeah, cool. I think that's it. Yeah, that's it. Summary of key concepts. We've got adenomyosis. It's abnormal location of endometrial tissue within the myometrium. It's associated with hypertrophy and hyperplasia of the myometrial stroma, which again, that's the thing that's presumably causing the symmetrical enlargement. That symmetrical enlargement is thought to at least partially be the reason why there is heavy bleeding. because you have greater surface area. But I think, as Matthew pointed out, presumably too, because of the enlargement, maybe there is some like compartment syndrome, like physiology, who knows, that you would have venous congestion, and maybe you have an engorgement of the capillaries and extra bleeding for that reason too. But there's a number of mechanisms by which you could make sense of this. And it also, that the fact that you're bleeding into the muscle causes the secondary dysmenorrhea and the tenderness, presumably because of inflammation. No one knows exactly why this happens, although it may involve the endometrium being introduced in the myometrium with surgery if you've had a C-section, although that is admittedly controversial, more controversial than UWorld would have you believe. And there is another thought would be that there's overgrowth of endometrial tissue into the myometrium, maybe from something like having lots of babies, being pregnant for longer periods of time, and they have more estrogen leading to endometrial growth. I'm going to end this here because we actually got through this very well. If you guys have any questions about this lecture, I want to start with those, and then maybe we have time to go over a couple other questions once I stop the recording. Any questions about these lectures? No? Feel pretty good. You guys seem pretty good about this, actually. This was good. I'm going to end the lecture here, and then I'll ask if you... Oh, Matthew, did you have a question?
Yeah, in regards to like the Anki aspect, are you like just copy pasting into the doc? Or
Is that all the bolded questions, we will put the bolded questions as cards. I write these are the more like integrated applied questions, and they will be in the lecture notes for each of these lectures. All you have to do is copy and paste them into your cards once we post it in a day or two. And it simplifies both the learning and the retention aspect dramatically in my experience.
And also regarding the decks, like I'm using my own deck, but it's merged with the pre-made deck, kind of what you said earlier about editing cards. Do you think that it's appropriate to merge this material on all of the same deck, or do you make a different deck? Or
great question. You're saying like you've got course material, you've got maybe the USMLE cards, and you've got pre-made decks, and you've got your own cards. You're saying, should I make one mother of all decks, the deck to end all decks, or should you keep them separate to try to have more like organization? Is that what you're asking?
Yeah.
It's up to you. Are you a lumper or a splitter? Oftentimes, I think that keeping them separate is probably better in many ways. It makes it a little bit easier. It makes it a little bit harder to review because then you've got to go through multiple decks to review. But I think that it makes it a little bit easier in terms of the organization, because oftentimes what you'll find is that the quality of the cards can vary drastically. And oftentimes one of the biggest reasons why they differ is mainly based on the source. Most pre-made decks, the quality of the cards, in my humble opinion, is not very high. They tend to be a lot of just like factory call closed cards. Like it's just very surface level, not even understanding, just memorization. I would try to keep those separate from like my main deck, because if I ever wanted to stop doing those cards, it would be very difficult if they were all in one deck. I would like to keep them separate so that I could suspend them all and just like quickly get rid of them if I ever decided to in the future.
Yeah. Can I ask one more? I know I have like this, but this is one topic where I'm like I have a lot of anxiety because I feel like I'm getting better at Anki. But like if I do what you say, like do you think you should use the pre-made deck continuously alongside like your cards you're making from this course? Just because the reason I ask is I feel like the style is very different. I mean, and I don't know what that really means for learning purposes. Like sometimes I don't know what you think. Like can someone use these cards and then simultaneously use like a different deck?
When you say pre-made deck, you mean like Sankey or Frozen Teflon? Or
I use Dorian. I don't use it's all the same. It's all based on Zanki anyway.
It's difficult. I'm gonna guess that you have had a way of studying for probably at least 2 or 3 years that revolved heavily around reviewing pre-made Anki cards. And you probably have a lot of like anxiety around not doing those cards. And there's a huge you've sunk a lot of time into this. It's very difficult to like let them go. Even if you feel like one of the cards is maybe not helpful, there is some utility left in those cards. And it's, oh my gosh, giving up on those cards can feel like you're throwing away the baby with the bathwater.
Yeah. I think besides the whole, like what you're saying, like aside from the feeling of letting something go, I think the bigger, I guess more importantly, like from a learning aspect, I don't know if there's some interference because the style of the card, there's different. And it's like night and day, you know what I mean? And I don't know. I don't know if anyone's ever done like a study on this. Not that I don't know if they could. I really don't know if you should be using such a different style of deck, because it can potentially confuse you. And then also you're just used to a certain style of cards. I don't know. I guess I'm asking if I don't know if anyone has that experience.
Totally. Yeah, I don't know. Andrew said, actually, Andrew, do you wanna address some of this?
Yeah, sure. Yeah, like I mentioned, I have 7 weeks left of dedicated. Our school gives us 8, but like the first week was weird because we had our emergency medicine shelf. Like up to that, I was still doing, for example, cards from my surgery deck, and basically, I didn't come across this course during the rotation year yet. What I did, like I had on King, and I would look at the tag for step 2 shelf deck for whatever rotation I was on, and I would just do all those. But yeah, like surgery, internal medicine stuff. A lot of it was like pretty rote memorization. But at the same time, I was doing like the USMLE pre-made cards that Dr. Palmerton has. And I was even already doing those in the last few weeks of my surgery clerkship, which was the most recent one, and concurrently studying for the actual surgery shelf. And at least for me, they felt compatible because with these exams, some of it is like conceptual question interpretation stuff, but then there also is some stuff where you gotta know the facts, like even if what's going on, like I was asking about earlier, if you don't know the certain details, then you're not going to be able to pick the right answer either. So at least in my case, I found mixing and matching was fun.
Cool. Yeah. And then do you give out, you have your own cards? I guess I'm assuming you bought the cards, but there's like a step 2 deck, I'm assuming.
You're asking me, is there a USMLE step 2
Oh, yeah.
deck?
Yeah. I don't know
There
if there's
is.
like I don't know if you have
There is.
you have a deck or something.
Correct. That is correct. Yeah.
Cool. Yeah. Maybe I'll just make 2 separate decks then.
I think your second question, I think, is also a really good one, which is how do you prove that any of this? Because I think when you've had many difficulties up until this point, when you've struggled, if you haven't passed a test in the past, like it's like you reach the point of desperation and you're like, oh my gosh, why is this not working? What's wrong with either my approach? What's wrong with me? What's wrong with these systems? And I think what we are desperately crave in a situation like that is to have some sort of certainty. You want to know because it's a big change. What I'm asking, this approach is radically different in many ways from what most people are doing in terms of just, a lot of people are just memorizing. And if you do a lot of closed deletion cards, if you do a lot of rote memorization cards, the question is if I spend the time to try to understand this, if I spend the time to actually make better Anki cards, is there going to be a payoff in the future? You've been doing something for long and it hasn't worked. And so the question is, I know that there's problems with what it is that I'm doing, but if I switch to a different method of trying to understand it and actually apply it, is it going to get better? Is that incorrect?
Yeah, no, I think I've accepted that the methodology works in terms of learning the material. Like I've accepted that that is the approach that everyone should be doing. But I guess concern is like when you have 2 different decks that have a different approach to the material. I don't know if it's possible to do that. It sounds like it is based on what Andrew said. But I guess I'm not discrediting the method. I think the method works in terms of learning the material very well. I'm just saying I think the style of your Anki cards, I think they have to be consistent for the most part because there's something with the learning system and you want to make things as consistent as possible. That's all I'm trying to say.
I see. When you're making your cards, they should all be like the style of either pathophysiologic phenology or I will say though, a lot of there are times if you can't do that, if you look at my cards, you will see cards that are just memorization. There are cards that I have that are just, I hate close. Even for memorization, I hate close. I for a variety of reasons, I think. It did not work well for me. And there's a lot of reasons why I think it doesn't work theoretically. But yeah, there are things that I just have to memorize. And I've made cards on brachial arches and stuff like that. That's not my
Well, yeah, and maybe I'll get your deck.
Cool. Now you know the key concepts that make OB GYN finally make sense. Next, you need the right practice system to turn that understanding into points. In my UWorld Complete Guide, I'll show you the exact phase-by-phase approach top scorers use to go from knowing OB concepts to crushing their shelf and step 2 scores with 260+ performances.